So today I'm going to be talking about how to evaluate small intestinal bacterial overgrowth, and I put in parentheses in irritable bowel syndrome. It's so common for our patients with chronic abdominal pain, diarrhea, constipation, especially bloating, who have disorders of brain-gut interactions like IBS, but who are coming in saying that they have SIBO. You haven't diagnosed me appropriately. I have bacterial overgrowth. So today's talk is really about kind of parsing out those details and all of the literature. This is a lot of what I talk to my patients about, understanding what our studies have shown in the past and what that means for diagnosis, treatment, and then also all the things that we don't know about bacterial overgrowth. So I have no disclosures. So the construct of this talk is in three parts. The first is really talking about how do I interpret the breath test? If we send our patients out for breath tests and we receive a report back, we want to know, is this following the consensus guidelines that came out in 2017? And is this consistent with true SIBO? So exactly what is a positive test? The second part of the talk will really be about what is the evidence for SIBO in patients with symptoms of IBS in particular. And that underlying question really that I think many people ask is, why should I get a breath test? Is the breath test really going to change my management? And then the third part is about what evidence is there for treatment. So functional bowel disorders are so common. 1 in every 4 adults in the US, Canada, and the UK has one of the 6 functional bowel disorders. And from this 2020 article on the prevalence of Rome 4 criteria for IBS, for functional constipation, for functional diarrhea, IBS has a prevalence of 4.6%. This is about half the prevalence comparing Rome 3 to Rome 4 because of a change in abdominal pain or abdominal discomfort to the Rome 4 criteria of only abdominal pain with a change to the bowels. Functional bowel disorders are more common in women than men, and they become less common after midlife. But if you were a patient and you log in your symptoms onto the internet, this can pop up very easily. It's one of the highest things that come up in searches of chronic GI symptoms. Instead of IBS, it's could it be SIBO? And once I read this, I get the feeling maybe I have SIBO. Maybe we all have SIBO. 10 signs you have SIBO. 1, gas, bloating, diarrhea. 2, abdominal pain, cramping. 3, constipation. 4, a diagnosis of IBS or IBD. And then if you read further down, even if you have no symptoms whatsoever and you're healthy, 6 to 15% actually have SIBO. So you may have it and you don't even know. And on top of that, if you have IBS, if you've been diagnosed with IBS, 80% of people are suffering from SIBO. It's not out of the ordinary then for us to get these questions from our patients and for us to consider, does this patient have SIBO? The idea and the link between changes to the intestinal microflora and IBS has been well laid out, right? We know that there's post-infectious IBS, that in all of these stool analyses that have been done, they do show a difference in the microbial composition between healthy controls and IBS, typically having to do with diversity. If you transfer the stool from an IBS diarrhea patient and you put it in an animal model, this induces changes similar to those with IBS, abdominal pain, change to the bowels. Recently, M-Smithii, or the methane producer from archaea, is actually linked to IBS constipation, which we'll talk about in other slides. And then we know that antibiotics and probiotics show benefit in IBS. But we've really simplified, I would say we as in the medical community has really simplified the idea of this link between changes to the microbiome and specifically in the small intestine with those symptoms of IBS as small intestinal overgrowth. That the idea is that bacteria are present in increased numbers, resulting in excessive fermentation, inflammation, or malabsorption. The pathophysiology of how SIBO can create these very common symptoms has been well laid out in multiple review articles and studies. Bloating can occur because of degradation of carbohydrates, so specifically short-chain fatty acids, and hydrogen, methane, and CO2 are created, leading to that bloating and gas. Diarrhea can develop because of carbohydrate malabsorption, fat malabsorption, hydroxylated fatty acids, and free bile acids. You can develop nausea, anorexia, bloating because of changes in motility due to these bacterial end products like nitric oxide. Abdominal pain can result because of bacterial end products. And SIBO, in severe cases, can result in anemia and weight loss. I would argue that's not true in most of the subset of patients with IBS who have SIBO, but these can result because of B12 deficiency when there's consumption by bacteria, deficiencies of fat-soluble vitamins, steatorrhea, and then elevated folate. So I'm going to start off the idea or the concept of interpreting the test by asking which of the following is a positive glucose breath test for SIBO. And so I've given you three choices here. This is across time. We're checking hydrogen levels, methane levels. And then in choice A, you can see hydrogen remains flat, methane remains flat across time. In B, hydrogen bumps up by 20 part per million by 60 minutes. And then methane remains flat. And finally, in C, you have an elevated but relatively stable hydrogen, and then an elevated methane. So the answer to this question is B. B is a positive SIBO breath test. The choice A is a negative SIBO breath test because both hydrogen and methane are flat. And then in choice C, this is actually a negative SIBO breath test because the hydrogen does not bump, but there is evidence of intestinal methogenic overgrowth. So let's get into the details, right? SIBO, the gold standard is jejunal aspirin. People talk about this all the time, but it's cumbersome. It costs a lot. There's false positives that can develop even from this. And the classic was defined as greater than 10 to the fifth organisms per ml, as the normal jejunal concentration is less than or equal to 10 to the fourth organisms. The North American consensus that came out in 2017 defined jejunal aspirates or small bowel aspirates, and the concentration is greater than 10 to the third CFUs per ml, and that's considered significant. But really, while this is the gold standard, this has all fallen to a secondary position because breath test is just so readily available. It's non-invasive, and everybody knows about it. And you can use glucose or lactose. So I'm going to talk about breath testing details. So the way that this test occurs is that the patient ingests a test sugar after prepping, and I'm going to go through those guidelines in a second. You ingest the sugar, and then this goes into the small intestine where bacteria are potentially located, and only bacteria are able to create hydrogen and or methane. And at that time, the hydrogen and methane gets absorbed into the bloodstream and then goes into the lungs. And then this is breathed out by the patient into this bag that we're collecting every so often. The consensus is recommended preparation for this study. You can get false positives and false negatives for various reasons. Antibiotics should be avoided 4 weeks before the test. You should stop the probiotic if you are taking one. And this is not clear, and there's not exactly a consensus beyond the North American consensus. If tolerated by the patient, you should stop pro-motility drugs and laxatives at least a week prior to breath testing. You should avoid complex carbohydrates the day prior to breath testing. Fast 8 to 12 hours before the test. Avoid smoking. Physical activity should be limited during the breath test. And then it's not necessary to stop PPIs. The most common questions that I get about preparation for the breath test is often, I can't stop my laxatives for constipation. I have to use it. Can you still do it? And then also, should I just stop the PPI just to make sure that it's not affecting things? And generally, I go by the consensus, which is that if possible, stop the promotility agent. But as we'll discuss later, it may affect and cause some false positives if there's an increase in motility. And then I generally do not stop PPIs. So we have available for breath testing in SIBO glucose and lactulose. So how do I choose, right? There is no gold standard, but there are caveats to each of them. And understanding first glucose. Glucose is usually given in 75 grams. Comparative studies of 50, 75, 100 grams has not been performed. Really wide-ranging sensitivity and specificity. So sensitivity of 20 to 93%, specificity of 30% to 86%. Glucose is absorbed in the proximal gut, and therefore we generally think that glucose underestimates SIBO with a positive predictive value of 80% and a negative predictive value of 61%. Lactulose, on the other hand, is given at 10 grams, also wide-ranging sensitivity and specificity, as you can see. Lactulose used to be an old oral cecal transit time estimate, right? This is not absorbed, and it will actually definitely go into the distal small bowel and will hit the colon, but it can result in that rise of hydrogen and or methane when degraded by flora in the colon, and therefore it can cause these false positives. So that positive predictive value is 61%, and then the negative predictive value is 54%. So in our institution at Beth Israel, generally, we recommend that glucose substrates for bacterial overgrowth because we would rather underestimate rather than overestimate bacterial overgrowth. However, now there are patients who have read up about it. There are providers who prefer lactulose and would prefer to overcall bacterial overgrowth and choose lactulose instead. The various studies that have been performed on breath testing really hinges upon the definition used in these studies. And so I'm going to go through the history of how bacterial overgrowth was linked to IBS, but I want to call out in particular that there were three major ways of defining positivity. So a greater than 20 part per million rise in hydrogen by 180 minutes. A double peak, meaning a rise initially in the small bowel and then a second rise that occurred in the colon. And then lastly, any rise of hydrogen before 90 minutes. This article in 2000 from the American Journal of Gastroenterology is the study that linked IBS to SIBO. And what they found was that IBS patients diagnosed by Rome 1 criteria underwent lactulose hydrogen breath testing. If they were positive, then they then underwent various antibiotics. This was not standardized. And then they repeated the lactulose hydrogen breath test after the treatment to confirm whether the patient had been eradicated or not. What they found was that almost 80% of patients with IBS had SIBO. And that successful eradication, meaning the lactulose hydrogen breath test after the antibiotics, if that became negative, successful eradication of that SIBO significantly reduced bloating, diarrhea, abdominal pain, such that 50% of patients actually didn't fulfill criteria for IBS anymore. In those patients who did not successfully eradicate, there was no change in those. So they didn't have any change to their symptoms. Subsequent studies in 2005, 6, and 7 have also reported a somewhat increase in SIBO in those patients with IBS. But the issue really is when you look at the criteria, every study has used somewhat differing ways of defining positive SIBO, and that we find lactulose hydrogen breath testing doesn't necessarily discriminate between IBS and healthy controls. So you can see here, if we're using that double peak criteria, Pimentel's study in 2000 that I just showed shows that very high prevalence. But if you use that same criteria, the black boxes are IBS and the healthy controls are in the white, there's not really a difference in subsequent studies. If you look at hydrogen rise of greater than 20 part per million, one study will suspect that or show that there's an elevation in SIBO in IBS, but other ones do not see such a difference. And then hydrogen rise, again, one particular study by Pimentel in 2003 that shows that really elevated prevalence of that abnormal breath testing by that criteria, but not so much in the other studies. So this is all to say that there were many different ways of defining positivity. But this is not accepted at this point because the North American consensus in 2017 has really suggested we should all standardize the way we accept positive or diagnose positive breath tests. And what that means is that SIBO now is defined as greater than or equal to 20 part per million hydrogen rise from the baseline by 90 minutes. On the other hand, and separately, there's this concept of intestinal methylogenic overgrowth, or IMO. And this is called IMO because it's anywhere, this archaea that creates methane is anywhere in the GI tract. And that means that greater than or equal to 10 part per million of methane is methane positivity, or IMO. And we'll talk about that again in a minute. SIBO is highly prevalent in IBS. This was the most recent meta-analysis that was done in 2020, showing that by their differing criteria, SIBO has an elevated odds ratio in IBS by 3.7, and that IBS diarrhea has a prevalence of SIBO of about 35%, IBS-C 22%, and in IBS-M 25%. By breath testing overall, there's a 35% prevalence, and by culture, 13.9% by more stringent criteria. And then if it's a little bit more relaxed at the consensus guideline threshold, 10 to the third, then the prevalence is 33%. It's important to note that comparing lactulose and hydrogen breath tests, if you use that lactulose hydrogen breath test by these studies, you're 3 times more likely to be diagnosed with SIBO compared to the glucose breath test. What is the reason why patients have SIBO? Just taking a step back, the reasons would be failure of that gastric acid barrier, failure of the small bowel clearance, like with visceral myopathy, connective tissue diseases, medications that slow down the GI tract like opioids, small bowel alterations like IC valve resection, short gut syndrome, right? And immunodeficiencies like combined variable immunodeficiencies, or IgA. Under that multifactorial category, we have IBS. What is the reason why patients have SIBO who have actually a diagnosis or can be diagnosed with IBS? Is it the PPI? We give our IBS patients so many PPIs that perhaps that's the reason. This population is targeted to have reduced acid suppression, increased acid suppression, and therefore increased bacterial overgrowth. This is just one study that I'm showing, and I always say there are 3 other studies that show the opposite of what I'm showing here, but that duodenal aspirates were performed for species in 897 consecutive patients undergoing upper endoscopy, and they looked at the prevalence of SIBO in those who were taking PPIs and those who were not taking PPIs. And you can see there's no difference between positive and negative, whether you're on PPI or not. And then specifically, they looked at IBS-D versus non-IBS-D, and there was no difference in PPI exposure, indicating there is no influence of the PPI on SIBO positivity. Is it motility, right? So multiple studies have been done. This in particular, this study was looking at this phase 3 interdigestive motility, these cleansing movements that happen approximately every 90 minutes in normal patients or in healthy patients. Subjects with IBS and those that actually were also diagnosed with SIBO had less of these cleansing phase 3 events, so 0.7 versus 2.2. Other studies have shown shorter MMC frequencies in IBS. There are various intraduodenal abnormalities, but there's not one particular overarching idea of what is wrong or different about patients who have SIBO and IBS. Is it that the breath test is influenced by transit time? This is a groundbreaking article in 2011 that was trying to evaluate where does the positivity occur in the breath test when the substrate is actually in the GI tract, right? And so what they did was they gave this lactulose hydrogen breath test to IBS patients, but simultaneously they gave a nuclear scintigraphy study. And what they found was that 63%, so a very high percentage, had abnormal lactulose hydrogen breath testing, and they waited until 180 minutes, so longer than the consensus guidelines. If they shortened it to 90 minutes, then that prevalence drops to about 35%, so a little more manageable. But what they found, what was so interesting, is that 88% of those with a positive lactulose hydrogen breath test already had greater than 5% accumulation of the cecum at the time of positivity. This is suggesting that actually the substrate has reached the colon and that we underestimate the time that it takes to get there. And that peak that we're seeing in hydrogen, or the rise in hydrogen, is actually from the colon. So another point that has recently come about in discussion and controversy is really that, well, we check for hydrogen, we check for methane, but should we be looking at hydrogen sulfide producing organisms? And so the whole idea behind this is that hydrogen is consumed by methogenic archaea to produce methane. And then there are hydrogen sulfide producing organisms that then produce hydrogen sulfide from this hydrogen. One small study that was presented as a poster did show correlation with hydrogen sulfide production and IBSD, but really more studies need to be done. So at this point, it is not clear what the role of hydrogen sulfide producing organisms are and whether we should be testing for it. So SIBO diagnosis in IBS is flawed. I say this to patients, I say this to other providers. An abnormal breath test could result because it can be explained by variations in small bowel transit time as opposed to SIBO. And that hydrogen may not correlate with the symptoms because we're not testing for all of the hydrogen compounds, right? Yes, you can test for hydrogen. You could potentially test for methane. You could also test for hydrogen sulfides. We are not sure about all the different hydrogen consumption bacteria or flora. False positives can develop because of rapid transit or oral bacterial flora, and false negatives can result because of delayed gastric emptying, slow small intestinal transit, and methane producing or non-hydrogen producing bacteria. So what do the major societies tell us, right? ACG, by their SIBO guidelines, I'm quoting here, no single symptom can be specifically attributed to SIBO. Symptoms often masquerade as other diagnoses such as IBS, functional diarrhea, functional dyspepsia, or bloating. And so the ACG for their IBS guidelines do recommend, so they suggest the use of breath testing, whether that be glucose or lactulose, for the diagnosis of SIBO in patients with IBS. And that they also secondarily suggest using or testing for methane using glucose or lactulose for specifically constipation. Both of these are based on very low level of evidence, conditional recommendations. AGA has remained a little bit more removed from that. They recommend that although IBS has been shown to respond to therapy with a poorly absorbed antibiotic, the role of SIBO and its eradication in the genesis of this response warrants further confirmation in randomized controlled trials. So they don't recommend particularly testing for with a breath test. If you look at the literature, however, the second point, besides the high prevalence of SIBO in IBS patients, is that breath testing does predict treatment response. And I'm showing here the Target 3 trial that is suggesting that it's indicative of response in IBSD patients. So they took 98 patients with IBS diarrhea with a breath test that occurred at baseline, and then after completion of a 2-week course of open label rifaximin, and then they were treated again in open label if they relapsed. What they found was that nearly 60% of patients with IBSD and who had a positive lactulose hydrogen breath test responded to rifaximin. On the other hand, only 26% of patients who had a negative breath test actually responded. Again, indicating that the breath test, if it's positive initially, could predict that you could respond, but that confirmation of eradication is the most likely person to respond. So response rate in patients whose breath test normalized after rifaximin treatment was 76%. So overall, A positive breath test, again, is an unclear predictor in non-IBS diarrhea patients. By this study, it's suggesting that it is a predictor, particularly in IBS diarrhea patients. Moving on to treatment, the first thing that providers talk about is really rifaximin. And we've extrapolated rifaximin because of really its safety and its effectiveness in IBS diarrhea. In this meta-analysis that looked at rifaximin in SIBO treatment, rifaximin was safe and effective. Symptoms improved or disappeared in more than 2/3 of patients, so 67%. And 2 studies actually showed a dose-dependent eradication, meaning it was actually less than that, 550 milligrams 3 times a day for 2 weeks, as is done with IBS diarrhea or is FDA approved for IBS diarrhea. But there are other antibiotics available, and this is from the SIBO guidelines from the American Journal of Gastroenterology. You can use not only rifaximin, but you can use amoxicillin, clavulanic acid, ciprofloxacin, doxycycline, metronidazole. So I think that while rifaximin is nice because of its safety profile, it's not the only choice that is available, especially with difficulties with insurance approval. What about IMO? So this intestinal methogenic overgrowth has gained so much following and belief that if we treat this IMO for patients who have constipation, that they could get better. Remember that 30 to 62% of healthy human beings have methane-producing bacteria in their gut, and it's by the consensus, it's defined as greater than or equal to 10 part per million of methane at any time during the test. And there's some debate about whether that should be a rise rather than set 10. This actually belongs to the domain of archaea, so it's technically not bacteria. And again, methylbrevy smithi is the key methane producer. It can overgrow or be present in the colon and the small intestine, therefore it is not a small intestinal overgrowth. This is the meta-analysis that was looking at methane positivity in correlation with constipation. So IMO and methogen creation is associated with constipation. Remember that these studies are based on also varying criteria of methane positivity. So you can see here that some studies even looked at greater than 3 part per million as IMO, some as greater than 20 part per million, etc. So very varying definitions that correlated constipation with IMO, but there are many studies at this point that do show the correlation. What evidence do we have for treatment? Methane production in IBS-C was studied in this very small study in 2014, 31 subjects given neomycin and placebo versus neomycin and rifaximin. And so what they found was looking at the severity of constipation, this improved in the neomycin and rifaximin group. It was superior to neomycin and placebo. Their definition of methane production was greater than 3 part per million, so not what is the accepted definition now, and patients were only followed for 4 weeks. So while there is evidence to show that you can treat IMO, the definition is different, the follow-up was very short, and that if you have a patient with chronic constipation, the patient likely will have constipation for longer than 4 weeks. So more studies need to be done. We still don't know a lot. And that's the limitation of our research and our just more drive that we have to look into a lot of these questions. Is there a better test out there besides breath test? Are we actually looking at the wrong thing? It's not quantity, it's quality. What about non-pharmacological ways of treatment and prevention? So many patients come to me having been diagnosed with SIBO, they're on FODMAP diet because their nutritionist, their GI recommended FODMAP to prevent it. We don't have any evidence at this point that FODMAP decreases SIBO. Do probiotics help? Do they hurt? Are there other herbal remedies? And finally, how do you treat recurrence? So for those people who have repeated bouts of SIBO, and they do somewhat get better with their symptoms after treatment, could you actually treat again and again? In a retrospective study, they looked at this rotation, and what they found was that in this small study of 20 patients, quality of life and bloating did improve. So in summary, IBS is associated with increased abnormal SIBO breath testing, and a subset may benefit from evaluation and or treatment. Breath testing with glucose and lactose is limited because of poor sensitivity and specificity, with false positives specifically due to transit. IBS, especially the diarrhea subset, with positive breath tests are more likely to improve after antibiotics, especially if you confirm eradication. And that's a separate discussion about whether or not you would actually do that in practice. But in the studies, it has been demonstrated. ACG recommends using SIBO breath testing to evaluate for SIBO in symptomatic patients with IBS as opposed to empiric treatment. And patients with constipation may have IMO. More studies are needed about that.